Outcomes and counseling parents. May I request the chairpersons to introduce the speaker?
Hello, good afternoon everybody. The next speaker on perinatal asphyxia is Dr. Sunil Gavhane. He is the head division of neonatology at MGM Aurangabad and the chief neonatal services Endo World Hospital Aurangabad.
It's okay. चालेल पॉइंटर ठीक आहे थँक्यू हो चालेल thank you. Since morning we are discussing about outcome, intact survival, magnesium, steroids, all these things. Again, golden hour also just now we discussed. Sometime it might happen, we have taken a lot of care, everything was going fine, and suddenly what happens is, and most of the time it is unexpected. Most of the time it is like that we are not expecting, and the delivery which are taken care so nicely for last 9 months catastrophically ends in what is called as perinatal asphyxia, and baby is limp at birth. Nobody wants that. Actually all of us have taken care of the pregnancy so well, monitored so well, and it suddenly happens that baby is limp, and now the problem starts is like, what next, what will happen to the baby, what will the prognostication and counseling. Frankly speaking, it is a very delicate thing, but yes, at least how we can prognosticate and how we can counsel the parents, that's what we are going to see in next 20 minutes. What all things we are going to see is importance, why we are interested in these topics. Again, what all things can help us in prognostication. One is cord blood analysis, AVGAR, clinical examination will help us, imaging, that is structural aspects, then functional aspect is like EEG, and there are some unresolved issues. Still some cases we can't prognosticate. Now why we are discussing these topics is there are two things. Nobody wants any child to have what is called as CP or bad neurological outcome. See, one child with CP, here in our scenario, Indian scenario, still we are not well equipped with follow up these kids, and we don't have special schools or training things for these kids. So nobody wants that. So we should know which baby is going to have this problem and which baby is going to be normal. That is one thing. Nobody wants this from pediatric side or obstetric side, both. And other is this one is, nowadays we are scared with all these things. Everybody, at least not yet in India, but all the obstetricians should have one medical legal consultant with them, should have, because of these problems. Anything goes wrong, either obstetrician or pediatrician is blamed, and the compensation is going in crores now. See the amount, 1 crore rupees somebody has to compensate for poor resuscitation, or oxygen was not there in the resuscitation room. So bad. Somebody's full life savings will go in that compensation. So this is one more thing we should know, that which baby is going to be bad or neurologically abnormal later on, so that we can take care from initial first day itself. And we can prognosticate, we can counsel it accordingly, and we can save our skin. A lot of things are said, magnesium, steroids, all these things, but still CP rate is constant in India, even because a lot of small tiny preterms are surviving. Sir is saying that now 22 weeks, 32 weeks, but at the end what is happening? We are still getting cases of CP and abnormal outcome. Now, to define something called as intrapartum hypoxic event which had led to bad outcome, few things we should be very clear when we are going to medical legal things and birth aspect and prognostications. We should be 100% sure that these are the essential criteria, first 4 should be satisfied to say that this baby had bad outcome because of something happened in perinatal period. Important is, first is metabolic acidosis, important is metabolic acidosis minded, not respiratory acidosis. When you are doing the ABG for the baby which is delivered, who had asphyxia, and we are doing blood gas, it should be a metabolic acid pH should be less than 7 and 12 to justify that this baby had acidosis. Other is early onset, moderate or severe encephalopathy. Baby was acidotic, baby had signs of encephalopathy, moderate to severe encephalopathy in the neonatal period. CP of spastic, quadriplegic or dyskinetic. Only these two are qualified as having CP or because of parental asphyxia, not something like diplegia, which is because of IVH, not because of hypoxia. Dyskinetic is because of basal ganglia mainly involvement, and exclusion of other identifiable causes such as trauma, coagulation disorder, infection, all. These four are essential, must to say there was a hypoxia, perinatal hypoxia led to bad neurological outcome. This is must. And then other criteria collectively suggest that there was intrapartum timing. In that is sentinel event, something like cord prolapse or abrupt show or sudden sustained bradycardia was recorded in that. Apgar score was low, multisystem involvement first 32 hours, and evidence of other early non-focal cerebral abnormality. So, first four are very, very important. What are the options with us to find out which baby is going to fare badly? One is delivery details. As I said, some sentinel events are there, CTG abnormalities there, fetal hearts were abnormal, that we can document, history is there. So, there are some events occurred which now we can at later on retrospectively correlate that. Other is cord, which have Apgar score we can record, neurological examination we can help in prognostication, EEG can help, neurosonogram, Doppler, that is structural, MRI and spectroscopy. These are the actually things which have in with you which can help you in prognostication in first week itself, which baby is going to be abnormal and which baby is going to be fare normally. Placental gas, again, which one is artery here and which is vein? All are obstetricians, most of the pediatricians they are collecting sample, but can somebody tell which is artery and vein here? This is umbilical cord, which is umbilical artery and which is umbilical vein? How many of you people are doing umbilical artery ABG? See, umbilical artery ABG is one thing which is must, not a single artery, but two vessels sampling is must nowadays. It is for two purposes. One is if baby is having asphyxia, to record that baby has acidosis, and other is if it is not of your fault, not obstetrician's fault that baby had hypoxia, you can save your skin. If cord ABG shows pH more than 7 and base deficit is less, you are 100% sure, or you can say that it is not something related to labor, that baby was asphyxiated or hypoxic. This is artery, which is small one. The vein will be very prominent, but artery will be small collapse sort of thing, that is artery. In any experience, and even the arterial sample, if you collect the arterial sample, most of the time chances of mixings are there. So, collect two vessels, and this is recommendation, ACHG, RCHG both are recommending that this two vessel sampling is must for all the deliveries, not only high risk, all the deliveries, it should be done. Other thing is, suppose now from obstetric perspective, you have a baby which was depressed at birth, mother came in the delivery area or emergency area, cord ABG was done and cord ABG showed the pH of 6.9, PCO2 of 85 or 90 and bicarb was 12 and base deficit was -6. Now, what we can justify from that cord ABG? What it suggests? pH of 6.9, it is badly acidotic, PCO2 of 90 on the cord ABG. This is respiratory acidosis, not metabolic now, and bicarb was suppose it was 12. Now, if you negate that respiratory component from the cord ABG, above 50, suppose there was 40 points, almost cord ABG PCO2 was 85 or 90, if you decrease that acidotic part from your pH, then effective pH will become 7.2. What you are trying to say is, when the mother came to you, this was acute event and you have taken the mother emergency cesarean, suppose within 20 minutes, you have found that CTG was abnormal and immediately you have taken the mother for cesarean as an emergency section, though cord ABG was 6.8 was acidosis was respiratory and not because your delay, baby has hypoxia. So, that is the importance of cord ABG, doing ABG. Now, is it going to help us in prognostication in isolation for the baby's outcome, long term outcome? In isolation, even if pH is less than 7 at birth and baby was acidotic or hypoxic, isolation it is not going to help you to prognosticate. You should have other things, clinical examination, neurological examination, functional component or structural component to prognosticate that baby. So, cord ABG in isolation should not be done used for prognostication. Yes, it shows that baby at that particular state was very bad, morbid, but yes, it can't be used isolated for prognostication. Yes, the baby is at risk of more of mortality and morbidity, but you can't use as a prognosticate factor isolated. So it is essential to have less than 7, and absence of metabolic acidomia precludes acidemia as a causative factor for CP. So it should be a metabolic acidosis. Other thing is ABGA score, which we normally do for all the babies to say birth asphyxia. This should be the ABGA score to say this is baby having birth asphyxia. Again, ABGA score, like COD ABG, is a static evaluation. At that particular point of time, how was the baby, or how the baby responded to your resuscitation. So that's the importance of ABGA score. ABGA score is not going to help you or prognosticate. Sometimes you are given sedation, sometimes you have magnesium, baby had poor respiratory effort. That doesn't mean baby had birth asphyxia. So ABGA score only tells you at that particular moment how was the baby, how is baby's clinical scenario. It is not related to your previous events, or it is not going to tell you what is going to happen later on, but what is going to say at that particular moment what is baby's evaluation. And if you are going to resuscitate, ABGA score will improve, and that will help you, that resuscitation is helping you. But ABGA score, mind you, ABGA score or COD ABG in isolation is not going to help in prognostication. That means many babies are birth asphyxia, have normal pH as ABG said, and neonate with low ABGA score who are acidemic may be better in long term than those who are not acidemic. So catastrophic intrapartum event can occur without acidemia, like respiratory I said, acute events may not be acidotic that time. So ABGA score can be used just for evaluation at that particular time and for resuscitation purpose. Other thing is, when pediatricians are there, they usually write when the baby is delivered, it is baby having mild encephalopathy, moderate or severe encephalopathy. Clinical examination can help you. Any baby who is having moderate encephalopathy, which is lethargic or stuporous, and they have weak, upset, simple things we can make. Sucking, if it is poor, baby had hypoxia, baby was lethargic or stuporous, flat, hypotonic totally, no reflexes, this baby is definitely going to come into moderate or severe encephalopathy. Any baby who is coming into stage 2 or moderate or severe encephalopathy are going to have some problems. Babies who are flat, totally hypotonic, no respiratory efforts for 30 minutes, who are pale, no reflex on stimulation, this baby is in severe encephalopathy. And now these babies, almost 100% babies, outcome will be bad, 50% will die and 50% will abnormal neurological outcome. So clinical examination in first few hours can help you in prognosticate. Any baby who is stage 2 moderate, there is lethargic, not stuporous, and tone is maintained, some tone is maintained, or they have seizures. Any baby who gets seizures gets into stage 2 encephalopathy. In that case, if their tone is maintained, the respiratory efforts they come later on, these baby are going to have good outcome, most of them. Only few, 20% have some small neurological outcome. But any baby at first hours of life or ventilated but no respiratory effort, no stimulation, no tone, no spontaneous activity, bad outcome, 100% for sure. So clinical examination here you can help you. Other is EEG. Mind you, this is one thing which can tell you functional aspect of the brain. Even in first 6 hours, you can get the EEG done. The problem with EEG is, EEG we do is a conventional EEG, and the problem is most of the people don't know how to read the conventional EEG. Even the neurologists what will do, delta wave, beta wave, theta wave, but they will abnormal EEG, seizures are there, but you will not get clear cut report. Make a point, do ask neurologists to write down background activity, how is the baseline activity, is there any seizures, and if background activity is bad, outcome is going to be bad in even first 6 hours. What I am showing here in EEG is, this is actually a sleep wave cycle which is normal, and if you see this ABG, the activity, brain activity is very badly depressed, and in between there is spikes. What this shows is that background activity means brain functional activity is very badly depressed and there are spikes in between, or this is continuously low voltage activity. These are abnormal things. This is normal. This is continuously he is getting seizures. The waves, the electric activity is crossing 50, so that means this electrical activity is too much. Make a habit to read EEG and you will understand that if baby's EEG is abnormal in first 6 hours and that abnormality persists for 24 hours, you repeat the EEG at 24 hours, if baby is asphyxiated, this baby is 100% going to be abnormal later on. At 24 hours itself you can predict that this baby is going to be abnormal in long term. So as I said, in first 6 hours and first 24 hours you can predict outcome at 2 years of age. And those baby who have persistent EEG abnormality for 24-48 hours, they are going to be abnormal. This is what I am showing. These are mild abnormalities. and these are severe abnormalities. If abnormality is severe and persists up to first 1 or 2 days, the baby's outcome is definitely going to be abnormal death or abnormal outcome later on in this baby. But if abnormality is mild abnormality, the baby is going to be normal. So EEG will help you definitely, and it is functional aspect of the brain, and it is easy, bedside, can be done, but make sure that try to read the EEG and ask the neurologist to write specifically background activities, seizures are there, how the sleep phase cycles are there, and you can judge from that. Neuroimaging, one more thing, bedside can be done on day 1 itself and can follow, it hardly takes 2 minutes. If baby is having birth asphyxia, is having continuously flat or heart rate is 150 continuously, no change, cerebral edema. Ventricles are very chinky, there is snowstorm appearance is there, echogenic foci are there, and you can't differentiate cortex from the white matter. Simple thing that there is cerebral edema, brain cells have experienced hypoxia, and if this sign persists at 24-48 hours, baby is going to be abnormal. But if edema decreases, perfusion improves in first 6 hours, this baby may survive well, but at 24 hours again this energy is abnormal, at 24 hours persist abnormality, edema and echogenic signals, baby will be abnormal. MRI, one more thing, MRI can be done, mind you, if you want to prognosticate the baby on first day itself. 2 things can be done MRI, structural MRI or functional aspect, that is spectroscopy. When the cells are dying, what we can do is MR spectroscopy, it is lactate which is elevated, which will be released because of cell death, and that can be used for prognostication in birth asphyxia. See, this is normal, this is posterior limb, this is ventricles. Again, this is also same thing. Problem with us is try to make the habit to read the MRI or ultrasounds or EEGs. If you frequently read these things, you will understand what to see and how to prognosticate and what to do. Because most of the radiologists also, they are not very well versed with the neuroradiology of newborn or EEG of the newborn. So, in MRI when you are doing, please do ask for diffusion weighted images on day 1 itself. Diffusion weighted images, movements of the water, H plus ions which occurs in the brain. If baby is having hypoxia, there will be edema and the water movements will be less, and that will be picked up on MRI. So, this is what is there. Basal ganglia, this is basal ganglia involvement. Day 1, day 5 diffusion, and day 1 again, if 11 again T1 weightage, this is white part which is actually hypoxic part. This is the hypoxic part. So, changes might evolve, but can be picked up on day 1 itself. Any baby is having this basal ganglia involvement suggests that there is acute hypoxic insult, and the baby will definitely going to be abnormal, dyskinetic TCP. If it is a cortical involvement, slow sustained hypoxia for long time, most of the time there will be cortical involvement, and this baby will have quadriplegic CP. This is what pattern of injury you see, basal ganglia pattern, mild, moderate, severe, and posterior limb also involved. This is again the cortical involvement and subcortical involvement, white matter and grey matter both are involved, and in later on when there is a injury is severe, it might be like you can't differentiate white, and differentiation of cortical and white matter is lost, and this is diffusion weighted images again. So, in first day itself you can, if you want to ask MRI, please ask for diffusion weighted and MR spectroscopy also. So, this is what I am saying, lactate peak when the cells are dying, in MRI if you are doing, ask for MR lactose spectroscopy also. Lactate peak will be very high compared to the other thing. Lactate suggests that cell death, anaerobic metabolism, and it is very sensitive, most of the time sensitivity specificity is almost 0.8, 80%. Doppler, ultrasound can be done for all the babies who are hypoxic at birth. Doppler will show there is increased resistance. Initially what will happen, there is brain sparing effect will be there in stage, encephalopathy is there. Initially diastolic velocity will go on, but why the stage 3 baby is very bad, obtunded, hypotonic, Dopplers will be abnormal, diastolic flow in the brain, anterior cerebral artery and middle cerebral artery will be abnormal. So when the Dopplers are abnormal, definitely you are going to say that this baby is going to be abnormal later on. This is normal. Diastolic flow are increased or diastolic flow is absent, both are not good. So the resistance index, the resistance index, if it in the brain increases, if you do Doppler of anterior cerebral or middle cerebral artery, the baby is going to be abnormal. What you have to say is diastolic flows. Diastolic flow is increased, this is brain sparing effect initially, but when the brain sparing effect or the blood flow to the brain at when the cell dies, it is lost, diastolic flow will be very less. So what all things we have on the day one itself, we can do EEG, we can do clinical examination, cord EBG or ABGAR, not isolated but can help at that particular moment. MRI can be done, ultrasound can be done, and Dopplers can be used to prognosticate baby on the day 1 itself. But there are not much of studies on the combination of this test. Isolation, yes, we can use, but now it's time that we should see all these tests in combination, and can that be used for the prognostications. So, as I said, to have CP and label this CP was because of some hypoxic insult, we should have some distal related event, there should be proximal related event, neonatal encephalopathy and CP. So, all this should satisfy as criteria we have said to say CP, to say this is because of perinatal hypoxia, long term outcomes of bad. Still there are some unresolved issues, something like MRI on day 1 or day 2 or EEG continuously for 24 hours. In preterm babies, not all these tests are not validated, combination of tests has not had been evaluated to prognosticate. In counseling and documentation, I will advise, if you have all these tests done, write down the what your counseling you are doing, what is the current status, you sign yourself, relative signature also should be there, your signature should be there, and if possible, if it is audio video, it is good, because you do not know which patient is going to have problems. So, which patient at day 7 is going to be abnormal, if it is normal on day 1 also. These are the actually obstetrician, pediatrician and relatives. This is what happens actually most of the time. We ourselves on first, second, third day, we do not know what is happening to the baby. This is pediatrician, and the relatives is actually confused. Everything was going fine, and now he suddenly faced that birth asphyxia, edema, cerebral edema, MRI abnormality, EEG abnormality, heart is depressed, but he do not know what is, he is not understanding most of the time. An obstetrician do not want to understand what is happening, he just want to say that this baby should survive whatever at any cost. This is what normally happens. Again, this is actually, this is Christy Williams, this is one of the actually, this is, he is actually painter sort of thing. He has, his paintings goes for crores, he had CP. So, CP again, when your counseling is not, if baby some parents still they want the baby, if his CP, IVH is there or Doppler abnormalities are there or EEG is abnormal, still they want the baby, you can counsel them. It is motor basically disability, need not be always intellectual problems. So, prognostication is very important, documentation is important, and audio video if it is there, it is good. Thank you. Any questions?
Any questions?
Yes, ma'am.